To you all. Thank you for being here so early in the day. We have some star speakers today with us. Today, cataract surgery is generally considered as a very safe and sound procedure, very easy, straightforward surgery. But some situations need very careful handling, may be associated with more complications, needs more planning, and we should anticipate potential complications. And these cases, they consume more time, more stress for the surgeons. And if you are very careful to follow the basic surgical principles, you can get over and come out with a good result. So in the next 55 minutes, I have 7 speakers with me who will take us through some of the difficult Phaco challenges. Are the videos ready? Yeah. So we have here first Dr. Ragini Parikh from Mumbai, a senior cataract surgeon, who will talk to us on when primary surgery fails in cataract surgery, what next? Welcome, Dr. Ragini Parikh.
Good morning, sir. I thank the Kerala Society for inviting us to this Golden Jubilee Conference. Good morning, Chairman on the dais, and good morning, friends. So you always have to have a plan B in life because sometimes, even the simplest of cases may not go well and you need to have a backup. So mishaps can happen while doing mature cataracts, black cataract, posterior polar cataract. So what is the age of the cataract? Whether there is any history of trauma, you should know all this. So this is a video where you can see the pupil is very well dilated. This is the capsule which is stained with a dye because it is a white mature cataract. You are doing a good capsulotomy, and as we all know that a good CCC is a prerequisite to a good Phaco. Everything is good, you are doing a good phacoemulsification. There is a small amount of stress in the surgeon while doing this type of cataract because you are always thinking that, oh, this is a white cataract and whether I'll be able to do it properly. But with a good machine, it can be done. So here you see you are almost doing a good job. This is the last piece of nucleus that you are aspirating, and you are good. What remains now is the cortex. What we use for cortex removal is the AC maintainer and the single port aspiration cannula. So it is all looking very good. There is 360 degrees of cortex removal. You are almost done over here and you feel you are very safe. You managed a very hard cataract. And can you just see what has happened while removing this cortex through the 12 o'clock? The posterior edge of the cannula has touched the PC and there is a PC rent. So even when you think that things are going well, this can happen. So what do? This is the plan B. There's no vitreous loss, but you can convert this flap into a posterior CCC with the specifically designed forceps. Now here there is no vitreous, so vitrectomy need not be done. This is a central PCC, and for surgeons who are used to doing a PCC, this is very good in a pediatric cataract. This is a well dilated pupil and a hard brown cataract. You are doing phacoemulsification after a central capsulorhexis. So it is hard. You can do a good phaco. You are doing a good phaco and most of the pieces are removed. And what remains here is the cortex. Again, this is a very good device to do cortex aspiration. This is a single port cannula and the AC maintainer. You polish the posterior capsule, which is very good. You put in the lens. You are very happy that you are doing a good job. And you are almost home because what is now required is just hydration. But please note what has happened while putting the posterior chamber IOL, sometimes one of the haptics or the stretch of the bag. So let's recap. While putting this IOL, you have done nothing wrong. But sometimes these type of situations do occur. The delivery was smooth. There is a oblong pear-shaped PC tear, but there is no vitreous. Everything is good. So not necessary that you have to go and mess around every time. You can leave this alone if there's no vitreous. This is the third patient where you are starting phaco emulsification. It's a corneal tunnel. You are doing phaco emulsification. Please don't go into the periphery. This can lead into complications. As you can see over here, the chamber is very, very unstable. Normally in this type of phaco machine, the chamber has to be very stable. Now, while doing something with the chopper, can you see the leak from the sleeve? The leak from the sleeve is causing the unstable chamber and hence the PCR. You need to know anterior vitrectomy and that also an automated one. So plan B is here. First do an automated vitrectomy. There is a huge nucleus piece and it is better to convert this into SICS. Either the main incision can be closed or you can do it through the same incision. Put in an IOL and then you have to suture this wound. You have to be very, very careful while putting the IOL. Here, actually, we should have gone with a 3-piece IOL. So the lesson to be learned over here is that you should have a 3-piece IOL in also in the OT in case of such occurrences because you may not be able to put this lens. But if there is a bag available, then you can put this in the bag carefully without causing any problem. You can see these are some few vitreous stands. So always check the sleeve and the needle and the standby lens. Now this is a posterior polar cataract. Now even before you begin this case, you know that there is going to be probably a PC defect. And when you are doing cortex removal through the main incision, there is shallowing and there is some amount of giveaway which could have been prevented. So as the cortex is cleaned, you can see the vitreous. So anterior vitrectomy. Now these type of patients, even without messing up, there could be a PC tear. So the plan B should be always ready in a PPC that you have to have a vitrectomy standby because whatever you see on slit lamp also may not be what you see on the table and there will be a defect in such type of patients. So you need to have a vitrectomy standby and not to enter via the main port while doing cortex removal. This appears to be a very soft cataract and you are trying to divide the first division, but the phaco piece does not have any hold, the phaco probe does not have any hold over the nucleus, there is no movement, you are not able to divide. So sometimes what you have to do is what we will see now. You are not able to phaco. Whatever you do, you are not able. So maybe the power is not right. But here, this is the nucleus salute. You are trying to chop. But whenever such a situation occurs, I would suggest that wait, put in visco, assess the situation, and then go back in. The nucleus, there is no followability of this nucleus, and hence you need to step back. This is edited, but you saw that we came out, we waited, and we did what was to be done. The pupil is fully dilated. You can lift the nucleus completely as you can see over here and then chop it. The pupil constricts because of your handling. So be very careful that nothing is going on behind the pupil. The nucleus is lifted up completely. So in many cases, you know, your finesse goes for a toss. You may not be able to do a stop and chop and everything like that. And sometimes be careful while lifting with a chopper. You can lift it with a dialer because a sharp chopper may cut through the PC, but you may have to change even your technique of phacoemulsification to give good results. All the time remembering that use of viscoelastic to protect the cornea, keeping the patient in mind first, keep a plan B always ready and a standby surgeon, and if everything fails, leave it so that the patient gets the best results. Thank you so much. Thank you for the opportunity to present.
Thank you, Dr. Ragni Parekh, for the exchange of knowledge. Our next speaker is Dr. Prabhu Shankar. He is going to discuss about posterior polar cataract. Over to you, Dr. Prabhu Shankar.
Thanks, Dr. JP and Dr. Jason. Yeah, played. நான் ஆப்ரேட் பண்ணிக்கிட்டுமேங்க. Yeah, posterior polar cataract is the most challenging cases during Phaco. So always when you're planning a rexus, don't go try to make a large rexus. In case you have a PC rent, you have enough support for the IOL placement. So one basic thing is make a rexus around 5 mm, never hydrodissect. You can hydrodelineate, but even that's too risky. Suppose your hydrodelineation goes wrong, you might end up with hydrodissection. And this is an unedited video, and I'm just showing the patient around maybe 35 years old with a bilateral posterior polar cataract. So, very soft nucleus. So I've not done hydrodissection. Since it's a very soft nucleus, I'm just going with very low aspiration. So basically in posterior polar cataract, never allow your anterior chamber to get decompressed. So gently keep aspirating because the very soft nucleus it is, no issues. So I'm just gently trying to nudge the nucleus part. See, very soft cataract, everything is coming down easily. So submental nucleus, you have to be very careful. So your second instrument plays a major role during posterior polar cataract, and never allow the eye to get depressed. Now you can see the posterior nucleus coming out very safely. So the most critical step in posterior polar is never come out of the anterior chamber with immediately inject sodium hyaluronate to the side port. This is the basic step you have to follow in a posterior polar cataract, and you will never have a PCR. So always never allow the eye to get decompressed, fill the bag, and now I come out now. So once you come out, it's easier now. So the cortical wash also, same thing, go do the cortex wash. And again, the second step again needs to be followed, go inside again with the second instrument, instead of the second through the side port, inject the sodium hyaluronate. Never try to do any PC polishing, never go near the PC at all, because anytime you can have a PC rent anytime during Phaco, during IA, during IOL incision, and even during AC reformation also, sometimes the PC can open because it's a very weak PC. So things are very stable now. And lastly, you can gently place in the IOL. So don't try to exert too much pressure on the posterior capsule, and just you can place a foldable IOL in the back. So surgery is over. This is actually an unedited video. So you just follow the basic principles. Next video. So this is a posterior polar in a soft cataract. Next one. Video 2. So this is posterior polar in a hard cataract. Play panel. Okay. So little hard nucleus is quite difficult because chopping will be quite difficult. So it's the same basic principle, never hydrodissect or dilute. But again here the second instrument has a major role, because you'll say once one quadrant of the nucleus is removed, the quadrant under the incision is very difficult to maneuver. So either don't use a chopper, go back to a dialer and try to just disengage that nucleus. Somehow it will start moving around. So just hold on. So don't change much your setting, whichever you do routine Phaco, you can do it. So this sub incisional nuclear fragment is the one which is difficult to remove it. So always do all the maneuvers very gently. So once a small fragment is there or sub epinuclear plate is there, you can just leave it on. Again, the same basic principle has to be followed. Go inject sodium hyaluronate into the anterior chamber, into the bag, and come out. So never allow the capsular bag to get decompressed. So once the IA is over, so you don't have to really bother about the hydrodissection. So most of the Phacos, even without hydrodissection, you can proceed, because by the time you just do a chop and start do your maneuver, so it's the same principle. The two principles has to be followed when you're doing posterior polar cataract. Keep always deepening the anterior chamber and the capsular bag. So everything is under control. Third. So this is. So this is the most challenging case now. Posterior polar, posterior capsular dehiscence. The posterior capsule is already opened. So now the challenge, what to do? Whether you want to do a SICS or a Phaco. Play பண்ணுங்க. இல்லையா play ஆகல. இல்லையே இங்க ஒன்றும் மூவ் ஆகலையே. க்ளோஸ் பண்ணி ஓப்பன் பண்ணுங்க. Okay. Now you can see when I decided to do a Phaco in this case. You can see the posterior capsule opened under the nucleus. But still, I go ahead with the Phaco. The only thing is that posterior capsule dehiscence has been there for a long time. So probably the anterior vitreous is already absorbed there. And so lucky I didn't have any drop or PC didn't extend. So again, the same maneuvers are followed there. So the settings and all, the same settings routinely which you use so that the anterior chamber is always deep, no collapse. So all the maneuvers are very gently done. So you can see a large capsular opening behind the nucleus. So now again the same basic step is being followed now. Just before removing the Phaco probe, I inject sodium hyalurate into the bag. Okay. So now once the things are very stable, no vitreous, so I could able to place a IOL in the bag. So the basic principles of PPC are never allow the eye to get decompressed. So unlikely to have a PC recurrence. Thank you.
Thank you. And videos and basic principles have been given. Now let me invite Dr. Lahani, a national leader at the level of AOA and an excellent.
Thank you, Jason sir, and thank you very much, the Kerala Ophthalmic Society, Srini, and all the President, Secretary of the Kerala Ophthalmic Society. So this is about the suprahard cataract. So there is no any financial interest. So what happens when you are doing it? It is difficult to break, and the zonules are loose because it is a nuclear cataract. And once you are using more energy, then there is a endothelial damage. Then how to manage? So you will have to manage with you yourself and the setting of the machine. So you can use the high vacuum when you are using that. Then IOP, if you can maintain in the machine, you can maintain the IOP, and you should use here the adequate power for this. And you can also use the cohesive and dispersive visco to protect the endothelium. It is called the cell. Then this is just what I do: quadrant removal, pulse mode, direct chop. You can go for the continuous with high vacuum and trenching, multiple burst and burst mode if it is there in the Phaco. Now how do we manage? So as it is, it is an hard cataract. Then there are a capsule is not seen, glow is not seen, weak zonules. The endothelium going to get damaged, and then the trenching is difficult, and the PCR risk is always there in our backup mind. So you can have a dye-assisted rexis. Then the So the rexis can be done by the dye, and here whenever you are doing the rexis, so rexis should be slightly larger. Otherwise, the nucleus is very bulky, and when you are doing in the small rexis, then you don't know what has happened. But sometimes the piece is teared as the accommodation, that means the area which was less, and that tears the posterior capsule. So it is always better to have slightly larger rexis. Then the Phaco power modulation is very important. See the cataract, you can see the patients. Can you see here? It is a, always there is, if there is a white element inside, then in such situation, yes, you can use the direct chop. Here you can see the posterior fibers are very important. So whenever you are chopping, in the chopping you will have to use the, see here, separation till the center. Once you separate it, see here, the posterior fibers, and those posterior fibers, if we are able to separate, then there is no problem. Or otherwise, what happens once you are lifting the piece, that the posterior piece which is adhered to your one piece. So whenever you know that this piece is completely separated, then only you should go for the quadrant. Or otherwise, if you are doing the quadrant, then the other piece may trouble you. So in such cases, when it is a, can say, hypermature type, and there is also fibrosis, you can see here. So if you are going like this, then can the, again very important, so two instruments when you are using, so that instruments are very important. See here, so you will have to hold the nucleus and use both the instrument at same time. So and then separate it up to the center of the nucleus, so that that piece will be separated. And if the, you can make two pieces, one you can make two pieces, then half of the work is done, and then you can go for the one piece, or you can make four pieces, so as convenient for you. So this is, again you can see the, I have separated this, and then I will rotate. Always rotate it and bring it 90° to the tip, because it is not like the other this one. So, and then you can take one piece by one piece. So the chopping, when there is a white element is there in the hard cataract, then only you can chop. When there is a black element, yes, you can chop, but there you will have to be very careful whenever you are chopping that type of cataract. So then again, if you are technique, you will have to use whenever. Now see, this is a Centurion machine where I am using both longitudinal and torsional phaco, and you can see the nucleus is very hard. To the, you can say the black cataract, and see how it is difficult to chop. See here, you can see the torsional phaco I am using. When I am separating it, can you see here? You can see, and the IOP I have kept at 70. So here see the aspiration I have kept at 40, and vacuum you can see the, I have kept it at near about 500. See here the separation, and once see, again the posted fibers are very important, and once you make the two pieces, again see here I am making the another pieces, and once I make those pieces, then only I can proceed. See here the other side I am making it, and once I, the separation is very very important, and unless and until you know this, I think you should not go for the phaco. See, this is a black cataract. One should not go for the phacoemulsification of such cases, because the endothelium is then damaged. There is a straight keratitis, edema, and second day patient is very unhappy. So if you should not bring the ego if you are not knowing. It is better to go for SICs, and second day patient is very happy, and after 1 month the astigmatism is also neutralized. So if you have done more than 100 mature cataract, then go for the black cataract. If you have not done it, it is always better to have a cautions or the surgeon standby. You have seen both longitudinal phaco and Both Phacos are used when I am going for that. So how you can say the experience? I was doing it in the started Phaco 95. 98 you can see my cornea, and then 2000 you can see my cornea, then 8, 4 and 8 you can see my cornea, and the basic thing is now 21 you can see my cornea is transparent. It means the only experience can help you, not other things. So once you are experienced properly, then you can do it good. The take home message is stop and chop or the direct chop technique you can use. But if it is a black cataract, you should go for the, you can say the stop and chop, always better than the direct chop technique. Then use of ultrasound is very important. Here you will have more ultrasound and experience. So you can learn from your colleagues or seniors. And another important thing is choose what is effective in your hand. And if your hand it is effective, you can go ahead. Thank you very much. Thank you, sir.
Thank you, Lahana sir, for the excellent video-based presentation. Now I invite Dr. Jayaprasad sir. He will be talking about phaco in crowded anterior chamber and post-angle closure glaucoma eyes. He is the consultant cataract surgeon at Amardeep Eye Hospital.
Good morning. Sure. Good morning, all of you. Thank you for being here. And I am talking to you about a topic which is dear to me, working in a crowded anterior chamber. We look into operating on a cataract in nanophthalmos, in a primary angle closure glaucoma, post-congestive attack, and in phacomorphic glaucoma. We have 7 minutes. So, nanophthalmos, basically, you have to look at the fact that the eye is smaller, definitely less than around 20 millimeters. The sclera is thicker, 1.7 millimeters, and hence there is a higher chance for uveal effusion to happen. And the lens volume is the volume that is there in a normal eye. So lens is big, the eye is small. Uveal effusion problems and anterior chamber is shallow. That is the situation in nanophthalmos. And the IOL formulas we use for short eyes are Hoffer Q and Holiday 2 earlier. Now we use Barrett Universal 2 for all ranges of axial length. And we can do both optical as well as immersion scan by an experienced biometrist. Before surgery in a nanophthalmic eye, I always get the patient and the relatives and tell them that the potential, the chance of amblyopia being there, the need for multiple surgeries subsequently, the chance of leaving behind a high residual refractive error, the fact that you are working in a closed eye and that endothelium may get damaged and the patient may need a future endothelial keratoplasty. And mind you, nanophthalmos is also associated with Fuchs. And the potential risk of uveal effusion spontaneously or after surgery is very high. And these small eyes are the high risk of ciliary block glaucoma, the malignant glaucoma. So preoperatively, what you should do is give IV mannitol, 1 gram per kilogram body weight of a 20% mannitol, about 1 hour before surgery or 45 minutes before surgery. I usually do on the topical, but if it looks slightly difficult, a small pupil stuck, then I give a peribulbar minimal amount of lignocaine and bupivacaine and give a massage. What you see here is a Osher super, that is something like a spin hook, which Dr. Osher has designed to press on the eyeball from the inferior fornix against the roof of the orbit so that a repeated maneuver will get the pressures down. The idea is, by doing all this, is to increase the anterior chamber depth and decrease the pre-op IOP so that there is a lesser chance for uveal perfusion. And prophylactic sclerotomy with the surgery, with cataract surgery, previously every other case we used to do, but nowadays with phaco, it is advised, it's not essential because today's phaco surgery is done in a very close, tight compartment with the intraocular pressure being retained throughout the surgery. However, when you are doing SICS where you are opening up the eye and the eye goes into hypertonia for some time, it is always better to combine with sclerotomy. There is a study from Arvind. But if you put in a sclerotomy in Phaco, please remember, don't keep the bottle high because you can get, it has been reported to have vitreous coming out or the uveal tissue coming out through the sclerostomy. Keep your flow parameters low. So here we have nanophthalmos, a small eye, this is around 19 millimeters length, always decompress slowly, long incisions, the long incisions but very optimally sized incisions. Always maintain AC throughout by injecting OVD whenever you introduce or take out a flowing instrument like Phaco or the bimanual IA. Go to step down Phaco means as you come towards progresses in your cataract surgery, you bring down the vacuum from 400 to 300, 200, 100, and even I go to 75 for the last piece so that you don't catch the PC and taste the vitreous. And Helon 5 is the ideal one, though I use just regular Oracot. Oracot is dispersive OVD. Underneath that, I use the regular hyaluronate. And for phacoemulsification, I use a combination of chondroitin sulfate above and HPMC below. And in these eyes where the lens power is very high, this was ferrumber 40 diopters, and I always slit the tip of the cartridge so that the lens goes out smoothly without the surface of the optic getting damaged. So once you have that slit made, then the lens can be loaded. Usually injecting through this cartridge, a higher power lens is slightly more pressure. Please remember not to overshoot and go and hit the ankle, hit the bag and create issues. So very gently, very soft pushes so that it goes into the eye nicely. And always remember, hypotonia in the postoperative period is a complication which you want to avoid. Always suture the wound before you leave the table. If you have an unexplained shallowing of the anterior chamber on the table, please consider that you are getting a suprachoroidal hemorrhage unless proved otherwise. You can also get, if there is a posterior misdirection, you have put the bottle on, very high at the ceiling, then the fluid can go behind, push up, and that situation you can give mannitol, 2 pints of mannitol, pat the eye, put a cycloplegic, and keep it for the end of the day. Most probably, if it is a posterior misdirection, the vitreous gets dehydrated, AC will get formed, so you can do the surgery again on the same day or wait for a day and do it on the next day. This is another patient, very interesting patient, 40-year-old male patient had an AC iris glow phakic IOL, a nanophthalmic eye that was done 12 years back. After 1 year, severe inflammation, so explanted. And now for cataract surgery, IOL power is 36 diopters because the cornea was steep, so power came down, and axial length is 17.5. Always do the capsulotomy through the side port. Most important thing, don't lose your chamber, then you will have radial extension. And please remember, in all these eyes, always never direct the fluid under the iris, then you will have repeated iris prolapse and you will mess up. Use a Kellman's bent tip if you have, so that you will not distort the cornea while reaching the nucleus, so that your visibility is good during surgery, and always close the wound. So once again here the pupil has been, the Seneca release, pupil has been dilated with iris hooks, and then injecting the lens with the tip opened up like a crocodile's mouth or a beak, and the beak open so that the surface doesn't get damaged. This is of course under OVD. The IOL related issues include inaccuracy of IOL available IOL formulas, the spherical aberration involved in a large, very thick lens, the unavailability of high powered IOLs. Of course, now IOCare has started making customized IOLs for you, and the need for a piggyback or a bioptic or using contact lens or glasses for residual power. Next, let us look at post-angle closure glaucoma. This is one eye, AC is 1.3 millimeters. Post-acute angle closure glaucoma. Not able to reach the anterior chamber and do it without hurting the endothelium. So, trocar 25 gauge vitrectomy. Under irrigation from the anterior chamber, minimum vitreous is removed till the AC is deep under the fluid. And then you do it, then it becomes like a regular cataract surgery. And please don't forget to put one more One more peripheral adductomy. Induction cataract in a hypermetropic eye, almost touching. So here, what I do is I put multiple punctures, a can opener in the center, so that you have multiple radial extensions, so that your intralendicular pressure is distributed along all these lines, so none of them will reach the periphery. And then you go in and massage, aspirate out all the anterior cortex, and then you go with your, now you can, once the bag is decompressed, you can go with your Uttaradas forceps through the main wound also, and there is no issue, and do your axis, and that is it. So in a crowded eyes, beware of potential complications. Phaco is far safer than SICs in a nanophthalmic eye. Always get an informed consent and always stick to basic scientific principles. And with that, I think I'll stop. Thank you so much.
Thank you, JP sir, for that excellent and detailed video presentation. Now I invite Dr. Jason sir. He will be talking about idiopathic floppy iris syndrome. He is the consultant cataract surgeon at Jyothis Eye Care Hospital, Kannur.
Good morning. My topic is floppy iris syndrome. Floppy iris syndrome affects patients taking alpha adrenoreceptor antagonists. The incidence is 2% of, it affects 2% of cataract surgeries, and the incidence among alpha blocker users is ranging from 33% to 78%. And floppy iris syndrome is a triad of flaccid iris that billows in response to fluid current. And there is tendency for the iris to prolapse through incision. And there is progressive meiosis. Tamsulosin blocks alpha 1A receptor and it relaxes the smooth muscle of bladder neck. It relaxes iris dilator as well. This makes conventional dilator drops ineffective. Tamsulosin is not the only drug causing floppy iris syndrome. Other alpha blockers, some beta blockers, some antihypertensives, and some antipsychotics can cause floppy iris syndrome. In this video, you can see viscoelastics can be used as a barrier against floppy iris. The common complications of floppy iris are iris trauma, PCR, and vitreous loss. Pre-operative screening is important. You have to screen both male and female patients. Detailed drug history should be taken. If the post-mydriatic pupil size is less than 6 mm in a patient taking tamsulosin, floppy iris incidence is high. Long-term tamsulosin can cause atrophy of the iris dilator muscle, and this effect can last for years. So stopping tamsulosin before surgery may not be useful in all cases. To prevent iris prolapse, you have to make a triplanar incision. You have to make a slightly longer incision, and paracentesis should be small. This is to prevent iris prolapse through paracentesis. Trypan blue is used to visualize capsule during phaco. Trypan blue makes capsule less elastic so that you can easily do rhexis in a small pupil. Heavy viscoelastics reduce floppy iris. You can even do viscodilation with heavy viscoelastics. Coming to the most important technique, intracameral epinephrine, this improves iris tone by overcoming the adrenergic block. Dilute epinephrine with BSS in 1:3 ratio. Preservative-free epinephrine is used to eliminate endothelial toxicity. Adding epinephrine in the irrigation bottle is also useful in managing floppy iris syndrome. Epi-sugarcane is a mixture of epinephrine, lidocaine, and BSS+. This is also helpful in managing these cases. In this video, you can see intracameral phenylephrine used to dilate pupil. Here it is used to facilitate cortical aspiration. Low fluid parameters will reduce turbulence in the AC, which will decrease billowing of the iris. In this video, neophysiological intraocular pressure is controlling floppy iris. You can see the IOP kept as 30, and even the aspiration flow rate are at higher level, maximum level. If you can keep IOP at a lower level, even higher other parameters may not affect you. Coming to iris retractors. In extreme cases of floppy iris, you can use iris retractors. Here there is no risk of mid-procedure meiosis, but you have to make extra incisions and it increases the surgical time. The retractors may be arranged in a diamond configuration. That is, one retractor should be below the iris or very close to the, below the tunnel or very close to the tunnel, so that it will prevent iris prolapse through tunnel. But rings may not be so ideal for floppy iris because it can get peripheral iris prolapse and you may get some biloming of the iris. So to conclude, preoperative screening is the most important step. Increased lens thickness and decreased mydriatic pupil diameter were associated with increased risk of floppy iris. And intracameral epinephrine is the useful technique for the management of floppy iris. Thank you very much.
Thank you, Dr. Jason, for that excellent talk on IFIS management of cataracts. Now let me invite Dr. Reshmi, a young surgeon, and she will talk to us on challenges faced by a beginner. Dr. Reshmi.
Good morning, all of you. First of all, I'd like to thank Jason sir and JP sir for giving me this opportunity. Here I will be talking about challenges in Phaco for beginners. There are numerous challenges faced by a beginning Phaco surgeon, especially if you are the only operating surgeon in the hospital. So, I would like to explain few challenges that I think will be beneficial for the beginner surgeons. So, I divided it into 3 parts: preoperative, intraoperative, and postoperative ones. The preoperative hurdles, the most important one is the patient selection. You should always have a good rapport with your patient. Explain if they have any risk factors. Do proper blood investigations and get a physician fitness. Always check the A-scan report prior to surgery because you can have an assessment of the anterior chamber depth, axial length, IOL power, etc. and you can anticipate any issues. When you select patients, in the initial cases, it is better to exclude small sunken eyes, small pupil, shallow AC, extremely soft and hard cataract, those deaf and uncooperative patients, PPC, mature cataract, and highly demanding patients. You should have a good knowledge of your machines. The microscope should have good retroillumination, proper focusing, magnification, centration, and you should be aware of the foot pedal control. Phaco parameters and the foot switch controls should be familiar. Apart from this, we also need good instruments, anesthesia, and supporting staff. Coming to the intraoperative challenges, patient positioning is very important. Positioning of the head, chin, and the pupil should be considered. It is better to tilt the head slightly to the side because it prevents pooling of the fluid in the conjunctival sac. Slightly lift the chin so the dye comes in level with the microscope light. In order to avoid Bell's phenomenon, ask the patient to look directly into the microscope light and open both eyes simultaneously. It is better to keep the microscope axis at 15-degree oblique manner, the surgeon's head and neck in the primary position, and the patient's visual axis in the primary position. This will enhance red reflex. Also, drape the lashes properly. Never keep the speculum too much widened, and it can result in difficult instrumentation and increased posterior pressure. In the initial cases, select a peribulbar or subtenon, whichever the surgeon is comfortable, and later can update to intracameral and topical anesthesia. Coming to the incision creation, I prefer a triplanar incision which include a small vertical groove, a 2 mm intracorneal tunnel, and then entry into the anterior chamber, which is always parallel to the iris. Never dimple into the cornea, as it can result in a chevron-shaped incision and can result in a poor sealing technique. And also the intracorneal tunnel should not be more than 2 mm because it can result in difficult instrumentation, and if it's less than 2 mm, it can produce iris prolapse also. The side port is made with a 15-degree blade. Never make it too anterior because it can result in difficult instrumentation. So be careful that the blade is not rotating when you are introducing it. Always keep it at least 2 to 3 clock hours away from the main port for easy handling. Coming to the capsular axis, try to get a 5 to 6 mm capsular axis. Never keep the capsule floating inside the anterior chamber. Always keep it flat with proper viscoelastic. Hold the eye with the left hand. Always end from an outside in manner. If it is a smaller axis, and try to enlarge it as a part of second axis. Suppose you have a runaway axis. Don't panic. Put adequate viscoelastic and keep the capsule flat and unfold. Use a microaxis forceps through the side port. Identify the root of the tear. Hold it, and in a swift motion push it towards the center and complete the axis. This is the Little's technique. Coming to the hydro procedure, always remove excess viscoelastic in the anterior chamber prior to hydro dissection and thus decompress the anterior chamber. Fluid is injected just beneath the anterior lens capsule towards the equator. See the fluid wave. Always tap at the nucleus and remove the excess fluid before repeating the next hydro. Multi-quadrant hydro dissection is the one better. Inject fluid into the nucleus matter. See the golden ring, and that is the hydrodelineation. Once the nucleus rotation is complete, you can start your phaco emulsification. Go with a bevel-down pattern to make the trench. Give maximum power at the center of the nucleus because it is a biconvex in shape. The width of the tunnel should be around 1.5 times the phaco tip and the depth around 2.5 times the phaco tip. Or you can always check for the red reflex also. Rotate the nucleus and complete the trenching. Keep the instruments at maximum depth of the trench and then only separate. Always ensure complete separation of the posterior plate. This is very important. Suppose if you have a soft cataract, there is always a chance of cheese wearing of the nucleus. So here you can go for two options. Either you can hydroprolapse the nucleus through a 5 mm axis and then aspirate it, or in a stop and shop method, you can make a deep trench, separate it properly and then aspirate. Coming to the irrigation aspiration, I personally like the bimanual irrigation aspiration better. Always hold the anterior lamina of the cortex and pull it tangentially towards the center to avoid less stress on the sonules. Proceed in a clockwise or anti-clockwise manner, whichever is comfortable, because it is easy to remove the cortex from the adjacent area where it is already removed. When you load the IOL, always make sure that the edges of the optics is tucked under the groove. The haptics are properly folded. And you can always see it from outside whether it is properly folded. And when loading the IOL also, in the injector also, just withdraw and see whether the trailing haptic is entrapped within the plunger. While inserting, always use the dialer as a second instrument to assist because there is a chance of IOL flip. The leading haptic should go into the bag and gently dial the trailing haptic. The wound closure, always start at 50% of the stromal depth. Never inject too forcefully because it can result in DM detachment. If there is a small DM detachment you notice at the end of the surgery, it's always better to put a small air bubble in the anterior chamber so that it will be sealed properly. So the important points to remember is that Ensure the cannula patency before injecting anything into the anterior chamber. Always check the irrigation flowing in between. Do only if you can see properly. Be familiar with SICS or ECCE. Know the technique of anterior vitrectomy, 3-piece IOL and iris glow lens if needed. In the postoperative period, always see your post-op patients. Counsel for the other eye if they are happy patients, and refer, in case you want to refer to your patient to somebody else, refer only to a consultant whom you can always trust. So the final tips are: believe in yourself, always observe and learn, don't hesitate to ask for help, convert if needed, and critically analyze your errors. Thank you for the kind listening.
Can I have the lights on? Yeah. Excellent talk, Dr. Rishmi. For a beginner, I think it is very important that you should not say, I will do Phaco. Advise cataract surgery. Even now, in all my case sheets, it's only cataract surgery consent. What method I use is mine. I do around 95-96% Phacos, but still, every patient, right from the beginning, it's always cataract surgery under LA. That's one thing. And even when I started, 1995, there was no Phaco surgeon in my town, in Trivandrum. I was the first person to start. There was no vitreoretinal surgeon to pick up the nucleus from the vitreous. So there was tremendous amount of tension in you. First 100 cases, I didn't tell them that I'm doing Phaco. I told them after surgery when things have gone well, and it was only grade 2 cataracts where I was sure that I can do a hydrodissection, lift it up and take it out through a bigger incision. So always remember to do write in the consent form cataract surgery and under LA and not Phaco under LA. That is one. And second is be ready for any complication. Like you have your single piece iris glow lenses, anterior chamber lenses, 3-piece IOLs, ready with tensuro, tensuro prolene to suture the lens or one of the haptics to the iris. You have your anterior vitrectomy instrument, you have your higher end OVDs. All these things should be ready, prepared, and your lens, 2 lenses. Because the first lens can break, the haptic can go, the system may drop it down, you in your under tremendous amount of pressure can drop it down. So all these things can happen. So always have a standby lens for every lens that goes in. And ask your manufacturer to have an arrangement or the supplier to have an arrangement where they will provide you with one more lens, and if you are not using, you give it back. That is, these are the 2 points I want to tell. And it is open for discussion, please. Any questions? Prabhu has shown you how to do an excellent posterior polar cataract, how to manage. Of course, I manage slightly differently. I put in a trench first, no hydrodissection or hydrodelineation. I put in a trench first, and from inside the trench, I do a viscodelineation, usually with a dispersive OVD. So that goes behind. So even if there is a pre-existing PCR, it remains there. It remains there so that it doesn't go down once you are going in with your Phaco for the nucleus. And second thing, as soon as that posterior epinucleus is slowly lifted up, I immediately inject dispersive OVD so that it will go underneath, so that if there is a pre-existing PCR, that will be covered by this. Like managing any PCR for that matter, it's always injecting a dispersive OVD there, so it will act as a barrier that prevents vitreous coming forward. Then you inject a cohesive OVD which will fill up and form the anterior chamber. These are the few things that I follow. Anything else? Any other question you'd like to ask? You want to add some comments, Dr. Ji? Time?
Any questions from audience?
Well, then I think we'll close it. Thank you very much. Thank you for making this hall almost houseful. Thank you so much, and see you next year.